I'll give a rundown on the role of viscous supplements in conservative management of osteoarthritis of the knee and the hand. Just a background that both Dr. Chu and myself work in Bios Orthopedics Singapore at the Farrer Park Medical Center. This is a one-stop orthopedic center comprising consultations, imaging, physiotherapy, and a day surgery center. Let me start with a talk on the knee. 82% of osteoarthritis occur around the knee joints, often bilateral. How does it start? What is the definition of osteoarthritis? It is a disease of the joint that affects all weight-bearing components and some force-bearing components such as the hand. You may not be standing to get osteoarthritis. It involves the primary disease in the articular cartilage, the menisci, and eventually exposure of the articulating bony surfaces. These are the stages of articular degradation, and usually by the time it reaches bone-on-bone contact, we are talking of surgery. But prior to that, there are stages that you can treat them conservatively. If we look at a normal arthroscopic picture of the knee, you can see the pristine, smooth cartilage of the condyles of the tibia and the femur. Then it begins to get softening of the cartilage with wear and tear, and this we confirm as chondromalacia patella or the femora. And finally, when bone is exposed, this is graded as arthritis. What are the diagnostic symptoms? Medical history tells you that they come usually most commonly with pain, sometimes with limp, and say they are stiff in their movements. This leads to reduced activity and poorer function, and the fact that they don't want to leave the house often, which leads to frustration, depression, and especially in the older person's adjustment problems. Clinically, there's often a deformity, quite common in the Asia-Pacific region. Patient has a limp. There is synovitis and effusion, as you can see at the left knee here. This leads to reduced range of motion, and in the Asian population, the ability to kneel and squat is lost. Together with deformity, you can get ligamentous instability due to laxity of joints, and this has to be considered, especially when you're doing surgery. Plain X-rays are the mainstay of diagnosis, and what you look out for are narrow joint spaces. As you can see here, squaring of the condyles, tibia and femoral side, because normally they are rounded and contoured. Formation of osteophytes at the articulating surfaces, and also bone-on-bone contact. And you should have weight-bearing AP lateral and Lawrence skyline view of the knee to get the three compartments of the knee. Other radiographic features to note are varus or valgus alignment in the coronal plane, loose bodies, which you can see, and these are composed usually of chondral lesions, and these are cartilages, osteocartilaginous lesions you can pick up on the X-ray. There's chondrocalcinosis of the menisci, as you can see here, and then bone cysts, as you can see, subchondral bone cysts here, indicating of advanced joint degeneration. How do you manage patients with osteoarthritis? First, you have to tell them that there is no known cure for osteoarthritis. The detrimental functions that arise from it, as I mentioned, are stiffness, leading to impaired muscle strength, weakness in climbing stairs, for example, getting out of a chair, and reduced fitness and walking distance, so they're spending less time out of the house. All these are amenable to trial of conservative treatment before considering surgery, whatever the X-ray findings show. The basic principles of treatment include educating the patient about the disease, that it is a long-term problem, how to manage a lifestyle. Some people are still active and participate in sports, how to wear proper cushioning shoes, and the role of stretching before exercises. Pain control is usually in the form of medication, and this sometimes improve function and delay the disease process and its consequences. There are pharmacologic treatments with non-steroidal anti-inflammatories. There is level 1 evidence for short-term pain relief, and patients are usually quite happy, but there are side effects such as gastrointestinal disease and cardiac toxicity. Commonly used in over-the-counter are oral glucosamine products. These give level 2 and 3 evidence, but personally I've used it and it gives good short-term pain relief and also less symptomatic stiffening. Be careful in diabetics because the sugars can be raised by taking too much glucosamine products. Physiotherapy is another mainstay. How to tell the patient certain exercises they need to do to maintain their joint mobility. Weight loss is difficult to attain in the elderly, but this certainly helps in reducing the load on the damaged joints. Physiotherapy includes a range of motion exercises, where our late Prime Minister was a big proponent of. Hydrotherapy is useful, but then depending on the weather, people of a certain age who have not swum before will find it difficult to do this. Muscle strengthening through exercises like TheraBand exercises. And I found yoga to be a good form of balancing exercises and also to loosen up the stiff joints. Steroids injections are quite a common mainstay for many of you in the general practice. We use triamcinolone, and there is level 1 evidence for short-term pain relief. It is superior to placebo and for pain control in the early weeks of injection. However, it does not last for long, and there is a chance that the steroids injected into the knee can cause itself synovitis. I use steroids usually for degenerative meniscal tear, and these are usually acute from a position, say, from getting up from the floor, sudden pain on the medial usually, or the lateral meniscus. And I applied it in the direct injection into the meniscus using Camelot triamcinolone of high concentration with the addition of analgesic lignocaine 1% to tell you that you got immediate pain relief. Now we come to the mainstay of this webinar, which is the viscous supplementation. This concept was started many years ago, 15, 16 years ago by Pollards, and actually was first proposed in racehorses. Viscous supplement aims to reduce pain, lubricate the joint, restore homeostasis, and stimulate the production of hyaluronic acid in vitro and in vivo. And this hopes to maintain the joint environment by stabilizing and protecting the collagen fibrous network, the cells of the chondrocytes, and also pain receptors. HA is a high molecular weight gel. It's in excess of 1 million to 4 million Daltons. It's highly cross-linked, retains water within the molecules, and reduces friction by its viscoelastic property. It also reduces inflammatory cell proliferation, promotes synoviocytes that produce HA, and also the chondrocytes. There is a level 1 evidence for short-term treatment of this viscous supplementation. It is more effective than corticosteroids in the long term. in terms of pain, range of motion, and function. However, in the Asian countries, be careful of the source of hyaluronic acid. Some are bovine and porcine, and this may lead to religious restrictions. So be sure you know the source of your HA that you are injecting into them. Synolis is designed to amplify pain relief, and it does so in 66% reduction even after the first injection. It restores these viscoelastic properties of synovial fluid fairly rapidly, and we feel it's more effective than others. It amplifies the pain relief and improves mobility in knee joints. It has the antioxidant properties which preserves the sodium hyaluronic acid. Sorbitol is a key ingredient of Synolis. It's a natural antioxidant, free radical scavenger. It captures and holds more water by hygroscopic effect. It reinforces hydrating power of hyaluronic acid, and thus improves the viscoelastic properties of cushioning the articulating surfaces. The action of sorbitol also reduces by 3 times the rate of destruction of hyaluronic acid chain by the free radicals that are within the knee joint. Here's a diagrammatic representation of what happens. Osteoarthritis produces mechanical cartilage destruction, releases oxidant-free radicals which cause pain as well as degradation of the remaining cartilage. This leads to inflammation, destruction of chondrocytes, synoviocytes, and then this all lead to pain. Injection of Synolis gives you better stability and glucosamine glycan molecular weight retention. It also results in slower reduction of viscous supplement viscosity. So it cuts inflammation and it cuts the reduction of chondrocytes, and therefore it blocks pain. The final situation is when the oxidative state of synovial fluid is rebalanced. Here is a comparative staging of 4 viscose supplements in current use, at least in Singapore, if not in your own country. And you can see that Synolis gives much faster pain relief, higher degree of pain relief than the competitors. But all of them, they stabilizes around 3 to 6 months, in which another injection could be given in selected cases. Now for the injection of this knee, these are techniques which you can use in your clinic. There is the injection sites. The common injection sites are the suprapatellar injection sites, lateral and medial, and parapatella usually on the lateral. Sometimes some people give it in the medial side as well, but I prefer lateral side. Be careful of hitting the synovium. So this is the main fear as you push your needle into this under the skin, whether you are actually in the joint. So this diagram shows a needle injecting into the anterior fat pad, which will not be intra-articular. So do look out for the spaces which is just behind the patella ligament and also in the suprapatellar part. So these are the 2 best places to give them just very close to the patella. Where are the landmarks? Here are some points that I come very simple to follow. The landmarks include the upper pole of the patella. I use a cold pack, such as something you can get out of a cake box or a freezing ice pack, sports gel. Then I don't use lignocaine with this because we want it to be neat. And lignocaine injection will require 2 injections. So the cryogel or the cold pack will be enough to numb the skin for the needle to enter without much pain. I use sterile aseptic technique with the gloves and also a preparation with an iodine preparation. The green or black needle, 21-22 gauge, is the most useful because these supplements are quite thick. So using a smaller needle, you will get a lot of resistance. If you feel resistance, you must stop. And the idea is to place the needle just under the cartilage instead of you have to find the landmark. Some knees there are effusion, so we would draw out a separate empty syringe, all the effusion to clear the knee of swelling, because you will be injecting 2 to 4 milliliters of viscous supplement. Here is a knee video. That's the upper pole of the patella, the lower pole of the patella. We use the landmark that is in line with the upper pole so that we will be staying within the joint. You can use a preparation of iodine, povidone, to paint the skin around. In my demonstration, I will use a sterile pack. The needle is placed in the suprapatellar pouch, aspirated to clear any fluid, and then injection is done. As you can see, it is a fairly quick job. I've ended my talk, and if you have any live questions.
We have a first question. Cortisone injection should be used judicially for joints, synovial sheath, and tendinitis when indicated. I have heard from 2 separate patients that a specialist claims that it should be limited to not more than 3 injections in a lifetime. I find this quite absurd. Any comments?
Yes, I think that there is no fixed number of injections in a lifetime because you don't need the injections over a period of a long life. Some people do not recommend more than 4 times a year. The reason is that corticosteroids in the form that we give them in triamcinolone are basically insoluble crystals. So there is deposition of this within the knee joint. The other injection, the reason for not having multiple injections is the introduction of infection. So the sterile preparation of the knee must be done every time these injections are given. But there is no such number as 3 injections in a lifetime. So I totally agree with the person who asked.
So there's a question on whether the participant can have a copy of the presentation. So there will be a recording. The presentation will not be circulated, unfortunately. So we'll send you the link for the presentation recording. Okay, so we have a question from Dr. Tian Ho Cheng. What is the risk of an intralesional HNL precipitating a tear in a degenerative meniscus?
No, usually we give this to a already torn degenerative. What we do is take away the pain, the synovitis that comes with this. So we don't just give it to any point. And usually the patient's presentation is fairly acute. Sudden movement like a twist or getting up from squatting position. And the point of tenderness is exactly over the medial meniscus usually because of the location is more prone to the tear. So the lesion, the HNL injection does not really precipitate a tear because the tear is already present.
Thank you, Dr. Khong. Now we'll proceed to the live demo. And any further question, please key in the Q&A chat box. Thank you.
Okay, we have a patient here who has a valgus knee and has an injection before and found relief of pain. This patella is slightly tracking laterally. So location of the patella, where the injection site is over the top of the patella, straight down into the soft spot of the lateral sulcus. We use ice pack. You can get this from anywhere, including those that come with certain Japanese chocolates. The play is you place it for about 5 minutes before you inject, and you can see the marking over the center of the knee. So in preparation, you tell the patient to relax. You can feel the point of the lateral pole of the patella, lateral upper pole, and there is the spot that you are going to enter. In our practice, we use sterile gloves. Sometimes in the general practice situation, this may be pricey, but because the price of the injection is already so high, I think you can build it into your, absorb it into your cost. We use povidone, just 2 swabs of povidone. We have a little sterile paper, and what I normally do is I just open up the paper, tear a small hole, so don't buy the ones that already have holes, they're more expensive. Just make them into a small spot. I use a black 22 gauge needle. The syringe comes sterile, pre-packed and loaded. I normally use 4 cc as opposed to the alternative of a 2 cc, which might be used for smaller joints like the ankle or the hand. And so just a povidone, and we prepare the skin. Give it a generous wipe. The rest will be done by palpation. So you take out your sterile. So the upper pole of the patella is here. So you drop the line right down to the soft spot and feel the patella, and the pouch is here. The needle is placed right starting at the upper pole. I tense the skin a little bit and inject. And then slowly move it slightly towards the joint surface, because the synovium is superior, the joint is below. So injecting, you can feel that there's an empty space, and then it's just a simple, slow injection. The trick is not to be fearful, and that this is quite thick. So it feels there's some resistance. You can ask the patient, and when it's done, just straight out, and you can see all is finished. And then you just wipe it away. And we just use an alcohol cleaning wipe. Sometimes patients may be on antiplatelet agents, aspirin, and they do might lose a little bit even with a small needle. So you just give it a few seconds of pressure. With a small little plaster. And I usually, just rinse the knee, you can actually feel some of the fluid squishing around inside. Ask the patient to remove the pin. Okay, thank you very much. That's the end of the demonstration.
Okay, thank you, Dr. Khong, for the knee injection demonstration. Okay, we have a questions from Vietnam. Can the diabetes patient use Synolis VA? Thank you.
Yes, of course. There's no contraindication to using Synolis VA. There is no sugar in the Synolis. There is sugar in the glucosamine. So glucosamine is the one where you have to ask the patient's diabetic history.
Okay, we'll leave the questions and answer for later. Now we'll go to the second part of the presentation, and I'll pass the screen to Dr. Chu.
Okay, good afternoon. Can you all hear me? Okay, thank you for attending this session, and I hope that the first portion has been beneficial to you. I shall be covering very briefly the overview on the osteoarthritis of the thumb upper metacarpal joint. I'll be focusing just mainly on this joint and not on the rest of the joint osteoarthritis in the hand. The first Cmc joint arthritis is a very common condition affecting the hand, and it generally increases with age, affecting the females more than the male. And it is associated with joint laxity, as well as the type of occupation and the amount of stress that goes into the joint. It has been shown that the forces at the fingertip, at the thumb tip, actually increases by about 13 times by the time it reaches the Cmc joint. And sometimes with the forces in the thumb that can go up to 10 or even 20 kilos, the amount of force going down to the Cmc joint is quite a lot. The patient usually presents with pain, weakness of the pinch, as well as deformity, and the pain usually comes with gripping and pinching. So because of that, there's usually weakness of the hand, either in opening bottles or jars, and there may also be associated deformity as it progresses with adduction deformity and loss of abduction. As a consequence, there's compensatory hyperextension of the metacarpal phalangeal joint. When you do an examination, there is actually positive grinding pain. and there's also stiffness affecting the opening of the first wet space. X-rays is done with the AP and the lateral view, and the AP view is the actual robust view, which will show the CMC joint properly. For straightforward osteoarthritis of the thumb, MRI or other types of imaging is rarely needed. The CMC joint arthritis can be classified into different stages. In the early stage, there's actually more of ligament laxity, and there may even be widening of the space because of effusion or synovitis. As it progresses to stage 2, there's some narrowing of the CMC joint, and if there's any osteophyte or loose bodies, they are actually very small. In stage 3, there's actually markedly narrowed joint space and subluxed joint, and in stage 4, there's pan-trapezial arthritis. Here's a picture showing the actual trapezium after it was excised, where there's actually loss of cartilage and ebonation. Treatment can start with non-operative management, including activity modification and joint protection, splinting, adaptive devices, as well as some inner muscle strengthening. Medications such as painkillers or other kinds of joint supplements may be tried. Intra-articular injections can be given either in the form of steroid or viscous supplementation. There was a question about how many times you should give. While it is true that there's no absolute limit, I would be quite more judicious and not to give too many injections into one location or one joint. It is, as a guide, I do keep to about 3 or 4, and if it doesn't work, other kind of management or treatment options should be considered. Recent meta-analysis studies actually show that there is not much difference in terms of the actual pain or actual outcome comparing HA injection versus steroid versus placebo in these studies. However, they are actually non-homogeneous kind of papers that are grouped together. And in this study, it actually shows that in the medium-term pain activity, steroid is actually better than HA injections. Another meta-analysis study which also shows that IA, intra-articular corticosteroids, or HA do not appear to be more effective than placebo in CMC joint arthritis. However, if you look at some of the individual papers, there is a short-term or medium-term benefit in giving either triamcinolone or HA. And in general, triamcinolone or steroid is better for quicker pain relief, and at the medium term of about 6 months, HA is better. So for treatment of CMC joint arthritis, you can actually look at it either in the early or late stage. In the early stage, besides after you have attempted the non-surgical as well as the injections, surgical options would include arthroscopic debridement, usually with some thermal shrinkage with or without microfracture, and ligament reconstruction or metacarpal osteotomy. When it becomes late stage, where such procedures may not be helpful, either arthrodesis or arthroplasty in the form of excision with or without interposition arthroplasty and suspension arthroplasty or joint replacement arthroplasty may be done. If there is adduction deformity in the late stage and the patient does not want other options, metacarpal osteotomy may be done. This is a picture of an arthroscopic debridement where the shaver can be used to reduce to perform a synovectomy, and then the radiofrequency probe used for thermal shrinkage. In one paper, it was shown that there is actually improvement of pain and pinch strength after such a procedure, even at follow-up of up to 41 months. If there's a lot of ligament laxity and early joint disease, ligament reconstruction may be done. If it is late, the vasectomy should be done with one or other form of ligament stabilization, either with the Burton Pellegrini method or other kinds of suspension plasty, such as Walby's suspension plasty. Usually these will utilize the flexor carpi radialis tendon or the abductor pollicis longus tendon. Fusion can be considered in a younger patient who require more power. However, it decreases the range of motion, and there's also a risk of non-union due to the short bone for fixation at the trapezium. It is also said that there's a risk of hand arthritis in the longer term. So in general, fusion can be used for and is recommended for younger patients who require more force, such as in laborers, and vasectomy with ligament reconstruction for those lower demand patients or for the more elderly patients. More recently, joint replacement can also be done, and in this case we see the older form of silicone implant arthroplasty. But in the newer type, where both the trapezial component and the metacarpal component can be used to replace the joint, and in this case, the bipolar kind of design is also shown to be helpful for mobility of the joint. This is a recent case that was done, and this is the implant that was put in with good pain relief and good function. And this is the picture. Okay, so with that, I thank you, and now we will go on to the injection of the CMC joint. I will just go through the steps of what we will do later. First is to mark the joint, and then after that, to be careful when we do the procedure to make sure that it is an aseptic technique. We certainly don't want to introduce any infection into the joint. By putting a bit of protection on the thumb, you can actually help. It can help you to localize the joint with a needle. In more advanced stage of CMC joint arthritis, it may sometimes be very difficult to locate the joint with a needle. If necessary, some kind of mini C-arm or image intensifier may be used, or ultrasound guidance if available and if required. I usually give some small amount of local anesthesia, especially if there's difficulty in localizing the joint. The patient will feel a bit of discomfort, and usually the joint can only take about one mil of the HA injection. Sometimes with a little bit more, it's 1.5 mils. Okay. So are there any questions? If not, then I will proceed with the demonstration first. Okay, you focus on one. So today we have Madam, our patient with us, and we are going to do bilateral injections for her. She has bilateral mild osteoarthritis of the CMC joint. Okay, so first is to localize the joint. You can localize it by palpating where the joint moves. Okay, and sometimes you can even get a bit of crepitus at the site. And usually how I mark it is I will use a pen without the point, okay, just the pen itself, and pressing it against the site of the injection. And then you get a depression there. Okay, so that is going to be your point. And when you clean with the antiseptic solution, it will not be cleaned away, it will still be there. Okay? So I'm going to mark both sides first because I'm going to clean both at the same time. Okay, so that will be the two sites of injection. If the CMC joint is very stiff and it's difficult to localize the joint here, you can actually try to localize it from the volar side. Okay, normally I will use either povidone iodine with spirit, or in this case hexodane, which is spirit with chlorhexidine. Okay, now I just put that here. The most important thing is to ensure that you do not touch the site that you want to inject. So it's okay to touch other parts of the finger and the thumb, but do not touch, again, the site that you're going to inject before you put the needle there. Okay, you can keep it in this way. I'm preparing the choking injection and the J injection. Okay, so I'll be infiltrating a little bit of injection of local anesthesia to the injection site. Okay, slight pain. And then give it a minute for it to Okay, now what I do is I usually use the rest of the lignocaine with the needle that I'm going to use for the intraarticular injection so that I can test the location if necessary. So now I'm inside the joint. I can feel a gift, and if you want to, you can give a little bit of the local anesthesia and it should go in freely without any resistance. Then I will change my syringe to the HA injection and then give about 1 cc or as much as the joint can take. In this case, it is about 1 cc. Okay, then I will stop there. And then I'll keep the rest for the other side. Okay, because I'm going to give the other injection, I'm going to leave this part to our nurse. Now I will do the other hand. Yeah, just position it like the other side. Relax. Because I've used up the paper for the other side, I've gotten an extra piece. Okay, again, you can still see the marking. Can you still see the marking? Yeah, okay, that circle is still there. So that's the advantage of using the pen without the tip to mark, and you can still see. Okay, and when you wet it, it's even more obvious. Okay, so now I will do the same thing. I'll give the local anesthesia first. Giving it a minute to work. And then using the real needle. So check the bit of difficulty. Recognizing, okay, now it's in. I always feel a kind of a give. May I just give a little bit? There should be no resistance. And then switching to the initial injection. And that's it. Okay, it's quite full after giving 1 cc and you can't really give beyond that. So it's done, okay, both sides. Okay, is there any question?
Question from the floor. When performing a non-2USG injection, how do you avoid damage to the branches of the radial artery and superficial branch of the radial nerve?
Okay, the radial artery actually winds from volar to the dorsal side, more towards the base or in the middle part of the trapezium. So at the metacarpal joint level, the radial artery should not be in that level, and it should not risk damage. Yes, ultrasound can show where the artery is, but the ultrasound is unlikely to be able to show you any superficial branch of the radial nerve. And certainly the II does not show the artery nor the nerve. So there is always a small risk of maybe damaging a very small branch of the radial nerve. I think that is a risk that we may have to tell the patient, as with any injection around the wrist area. But I think the risk will be quite small because the needle size is quite small and the chance of hitting a branch of the nerve is quite low.
Thank you. And the next
Usually I would so the question is, what is the aftercare, right? Yeah, so usually I may continue the patient wearing a kind of a thumb spica brace to be removed as necessary and not to overstrain the thumb for about 2 weeks before they resume activity as tolerated according to the pain level.
Thank you, Andrew. Okay, the next question is, can PJ injection combine with lidocaine? How to administer when it is injected to the OA patient? Is it a mix or 2 times injection? Two separate injection?
I usually do not mix them what I did just now was to inject a small amount of the lignocaine into the joint to ensure that the tip of my finger is in the joint, because when you give just a little bit and there's no resistance, you know for sure that you're in the joint and not hitting any ligament or synovium. Having said that, I think I'm not averse to putting more lignocaine into the joint before you inject your HA, except that it may reduce the volume of HA that you can inject. I don't think there's much of a dilution effect because the water in the lignocaine will be absorbed relatively quickly.
Okay, next question. Which joints can benefit with injection with HA? How long does the improvement last?
For the hand, I would say the CMC joint is the most commonly used. Interphalangeal joint has been done before also, and the results are, I mean, there are benefits for both, and on the average, I think it is still beneficial for between 6 to 12 months. Yeah, I think that's what we experience.
How about for the knee? How long does it last? The Khong?
For the knee, you can use, I always tell the patient that you need a good 3 months pain relief to be considered effective. Many of my patients are in excess of 6 months, and some of them come back once a year when they want to go on a holiday or go overseas. They come for injection so that they can enjoy their holidays. As for the other joints, I've injected the ankle joint. The big toe is also sometimes useful. The hip joint I've injected, but that requires a radiological procedure under C-arm for osteoarthritis of the hip. I have no experience in stem cells because in Singapore, we are not allowed to do stem cell injections into knee joints. You may be talking about, what's the name of that? Platelet-derived growth factor, but I don't do that for articular surfaces. It's given to tendinous and peritendinous structures.
I don't usually do that for the hand injections, although there is a paper that I cannot remember the outcome. They actually combine both because theoretically the steroid works better for the shorter term, and then the HA works better for the medium term. So by combining them together, you actually potentially has the benefit of both. But one also has to remember that the volume that you can inject into the hand joints is quite small, so you may actually not get the full benefit of adequate volume of HA injection. So I think, yes, there is theoretical benefit for mixing the two, although I personally don't do them.
Okay, what are the typical flare rates encountered in your practice for viscous supplementation for the knee?
With cyanosis, I have not experienced any flare rate. In some of the older HA injections, it is quite known that sometimes patient develops a reaction. We are not sure exactly to which component, and sometimes to the point where you might be concerned about having caused septic arthritis in a patient that is a swollen, warm, and painful knee. But the modern HA that we're giving does not give this reaction.
Okay, the next question, besides technique, does the type of HA matters with regards to the incidence of flares? I think Dr. Khong answered a bit. Maybe you want to add on? Does the type of HA used increase the incidence of the flare?
Yes, as I mentioned, the older technique. I'm not at liberty to give the name, but some of the modern ones I have not come across flares. So just be careful to warn the patient that sometimes they may develop some reactive allergies to any protein that is given into the body.
What size of needles to be used for the hand?
For the CMC joint, I use 23 gauge. It's a bit of a compromise because of the high viscosity. You need a bigger size needle, but because the joint is quite small, I use a 23 gauge, which is sufficient for the injection, and yet it's stiff enough for you to get into the joint without causing too much pain.
Okay, I think there's no more question. So before we end, let me show you.
There's another question.
Oh, there's another question. So sorry. Can you read the question, Dr. Chu?
If multiple injection to the knee joint is given, any risk of septic arthritis? Maybe Dr. Khong.
Any injections into the knee, whether you are using steroids or HA, as always has a risk of causing infection if the aseptic techniques are not adhered to. So it has nothing to do with how many times you give it, but every time you give it, it has to be totally aseptic in the techniques that we are showing.
Yeah, I agree with Dr. Khong, and as emphasized, once you have cleansed the injection site, do not touch it anymore. So you have to localize the site before you start your cleansing.
Okay, thank you, Dr. Khong and Dr. Chu, for the presentation. Before I end, I'd like to share with you that on the 16th of March, we have a new publication of our study, the non-inferiority of a single injection of sodium hyaluronate plus sorbitol to Hyalin GF20, a 6-month randomized controlled trial published in the Journal of Advances in Therapy. So in this study, Synolis VA 4 mils was studied versus the gold standard, Synolis 1, 6 ml. So the conclusion, you can see that Synolis VA efficacy over the 6-month study period was equivalent to the most prescribed and studied device, Synolis 1, while it demonstrated a significant and fast pain relief with 41% WOMAC pain decrease at day 7, and allowed to a significant number of patients to have a reduction of co-medication, suggesting a positive cause-effect outcome. So thank you. And for any inquiry, please contact Susan, NG, or BIOS Orthopedic. And before we end, we would like 1 or 2 minutes of your time to do a poll question. Please give your answers in the next screen that you will see. We are about halfway to the poll. We'll give another 2 minutes before we end this poll. Thank you. There was one part of my question I cannot hear. There was one. Thank you all for this afternoon, and wish you a pleasant weekend. And thanks for taking part in the poll, and all the best, and see you again. Bye-bye. Thank you.